So my name's Penny Francis and I'm the team leader here at North Richmond Community Health in the Alcohol and Drug Program, and I'm going to talk about a small program that we did here and are still in the middle of doing. So we're learning lots of new things about working with people that inject drugs. So there's a few things and a few key phrases that I'd like you to remember. And I know it's hard, it's Friday afternoon. The pub is only about 30 metres away. So I'm going to talk about My Mouth project, where we got a small amount of money to work with people that inject drugs, where we wanted to look at improving their oral health in our needle syringe program. And for those of you that had lunch outside, you would have probably noticed some people entering around the side of the building. That's where our NSP is. So I'm going to talk a little bit about that, set the scene so we're all on the same page, and then just talk about the project. So in our NSP, we've got in our alcohol and drug program, we've got our needle syringe program, our outreach program, and our nursing program. And all of that is about working with people that inject drugs to reduce the harms whilst they do that. So we acknowledge that people will still use, and one of the phrases that I want you to remember is PWID. So it's people who inject drugs. We don't use drug addicts. We don't use users, although it is a technical legal term, punter. We do try to avoid that. But we look at how we reduce the harms of people that use. So we don't say stop using. We don't say abstinence is a good thing. We say whilst you're using, let's help you do that safer. So the way we do that is that we give out clean injecting gear to people. We don't limit what they require, and we give out as much as they need. So some people might come in and want 200 fits. Some people, and a fit is the barrel with a tip. Some people ask for different tips. Some people come in and use 2, and some people will come and use within 300 metres of the building. So you may have noticed some of that happening whilst you've been here today. We do encourage our people not to use near the school, but it's very hard to control what people do outside of once they leave here. So the aim of an NSP is to reduce the transmission of bloodborne viruses. And I don't know if many of you are aware, but we do have an outbreak of HIV in Melbourne in people that inject drugs. So it's really critical that we try and manage that and work in partnership with other NSPs and other services to limit the effect on the person and the wider community. So in our NSP, we see 135 people a day. We're a primary NSP where we've got it manned. So we've got the luxury of being able to verbalise health messages, work with people. Often they'll drop in crisis, and we support them to access services, mainly and often around accommodation. So we love the concept of the Magpie House. We love the concept of when we can work with other services to get what people need. Just in the right-hand corner, you can see there's a big difference between what people return and what people take out. And that's probably linked to the fact that we have lots of public injecting. And here in Richmond, we're the last space in Melbourne where you can, where there's an open street market to be able to purchase drugs. So I don't know if anyone was hit up this afternoon to say if they're chasing. So there's a few things you've learnt this afternoon. So often people will say you're chasing. Sounds like you're Jason. So you're Jason. So yeah, get it? Right. Good. This is just an example of where our people come from. So some people will think, it's all about the flats, and it's not. So many of our people that come to this, to the area come from everywhere. We have lots of people that come from interstate and from regional areas, but that would have been very hard to put on my map, and I'm technically, challenged. So this just shows you that they come in from the northern suburbs and a scatter from the eastern suburbs. And often when we have a police presence, people will come from, or they'll be displaced to the city or south of the river. And north and south they do intersect sometimes. So this is just the NSP. So I just wanted to show you where that is. So it's discrete. So that's one of the things that we think is really good. It's not signed to say big bright lights, this is where injecting drug users go, but the clients will know by the exchange symbol with the sticker on the right. So we've got a buzzer where we let people in. So the door's locked, they'll come to the door, we buzz them in, and we try and manage the amount of people that we see. This is just an example of the stuff that we give out. And we also give out condoms and lubrication. And we do down the bottom, there's just a campaign that we've got running at the moment. It's World AIDS Day on Tuesday, so it's about being prepared. So take more fits than you need, and same with the condoms and lubrication. So the project, My Health, My Mouth. At the moment, we've screened 17 people. We've done this in the NSP. So although we realised we've got the oral health program upstairs, we identified that that was definitely a barrier for clients. Although we could walk them up, we'd often, in between going for the NSP upstairs, we would lose people. So we thought, hey, let's bring the oral health team down into the one of our rooms and see how we go. So we've had a range of questions where we'd ask the clients around their oral health status, and we would ask them around their injecting drug practices and their other drug taking. Now, I've broken it up into 3 sections. Assessment, so what do we actually look at when we assess them? And this would be no news to any of you. Everyone would recognise that often very hard client group to work with, poor oral health status. They know that their oral health is very, very poor, but it's really hard to get them in. So we tried to look at ways, how can we get people to come to our service and to be able to maintain and improve, then maintain their oral health. So we found the appointments, even in the NSP, free oral health assessment, they still wouldn't come. Then we'd look at the clinic, we'd say, hey, it's on at this time, still wouldn't come. I've got to go get on, or I've got to go do business. I'll be back in a minute, and then they don't come back. So we thought, well, we can do drop-in. And what we've had so far, we've had one person progress through to dentures. So although you might be like, oh, geez, that's not many, that's actually, we think it's a really good achievement. I did speak to one person, I'll talk about this now. I went and said to one guy, I said, which is different to the one I've just mentioned. I said to him, look, you've done a really good job. You've been able to make your appointments. And although you did turn up late and we turned you away, would you be interested in giving me some information that I can come and talk to you people today? And he goes, what? About going to see the dentist? I said, yeah, because you've done a really good job and lots of people find it really hard to come here. He goes, yeah, I'd love to, but I'm going to go to jail on Thursday. So although he was motivated, he'd started to progress on his oral health. He had some impacts for him to be able to fill his appointments and to be able to improve. So that may affect, or probably will affect, his ongoing treatment. So that just gives you an example of some of the barriers that the clients face. They know that their oral health status is bad. They're often really embarrassed. Often they'll come into us, they'll cover their mouth, and this is all the stuff that you know. And often they'll talk about how they've been treated badly. So when they go into a different service, they'll talk, and this is not just a dentist, this is everywhere. There's such stigma and discrimination, and that's when they come into an NSP, they know that's our job. We have to treat them with respect, no judgment, and we try and help them navigate the health system. And this is what one of these projects we aimed to work on. The image on the right is one of the participants' pics here that we've got. And I'll talk a bit more. So some other barriers that we need to consider is often their phones change. They lose their phone numbers. So you might send out your text reminder for your appointment, go, we've sent out the reminders, we're doing everything, and they don't show up. That's because they've had 4 phones since their last appointment. Really complex. Daryl's spoke about how often they're homeless, transient, moving around, couch surfing, staying at mum's, staying somewhere else, just got out of jail. The list goes on. Often there's a lack of motivation to change. So what we found with our clients was that they were, because they were current drug users and many people were still in crisis, the motivation to change, although they were really self-conscious of their smiling, covering their mouth, they still weren't motivated to change. So although we try to eliminate some of these barriers, that was something that we had to just basically accept. Often too, we've had to give clients a stern talking to and say, don't get as ripped as you did last time because you couldn't open your mouth. And when you go to the dentist, you've got to be able to open your mouth. So we had to talk them through, go to the appointment and say, if you're too stoned, we're not going to take you. So literally talking around the impact of drug use and how to just get to an appointment for an assessment. So how that can take lots of time and lots of work. So we have to remind them, we'll ring them up, we might see them out on outreach, say you've got your 2 o'clock, come back at 2 o'clock. Don't come, don't use before, you can get on after. Oh, yeah, all right, I'll come back. Okay. So also for us, police presence has a massive impact on people being able to access the service and then coming into appointments. So they'll avoid the area, or they may use more than they would have expected because they're fearful of being charged. So that has an impact on people being able to get to appointments. And they've just given us feedback around the barriers to the project. Like the questionnaires are too long. And also in the, with working with people that inject drugs, very, very commonplace for incentives to be provided. So Martin and I'd have this debate about, well, I'd say, Martin, whenever we do any survey with this client group, we'll compensate them for their time. So $10, $20. And that's commonplace. That any researcher, any program will tell you how that's what you do. So that was one of the barriers for this project, because we didn't want to do that because we knew that it wasn't sustainable, and that's what we wanted to look at, how it could be sustainable, but it's definitely had an impact on our numbers. We last year we tested 128 people and we had them knocking on the door, but the thing was we paid them $40, and we wanted to pay them $40 because that's around the amount that you can pay for to score for a hit for heroin, and we didn't want to pay less because then there was a risk of sharing. So these are all the things you've got to consider about how you can engage the client group to be able to come to your service. And I'm not saying that every dentist now needs to pay their client to come to them, but in terms of looking at barriers to reduce, to be able to access your service, that's stuff that we need to think about. So for us, what do we change? It meant that we, as an NSP, were more aware of some of the barriers for people around their oral health. We've done more oral health promotion in the NSP, more giveaways, and we'd be quite reluctant to give out the toothbrush because we knew the toothbrush wouldn't see the end of the week. So now we just give them out more frequently, working with the clients around if they've got stuff, and being probably more assertive in having that oral health conversation with clients. We've developed some resources, and we've also trained up our NSP staff to be more part of an integrated service. So they've learned how to use other client management systems. So rather than saying, go upstairs to dental, we've said, how about we can make that appointment for you now? So the clients really love the fact that they've been integrated. What we've found also for the oral health team, we've seen that there's been an increase in an understanding around some of the barriers. So that the social determinants of health, I think, have staff have become more aware, and some of the barriers that affect people not to get to their appointment. We've done a bit of advocacy around if people turn up late. So if they turn up late, is there opportunity to do some treatment rather than no treatment? And looking at what can we do? I think we've got a 3 strikes and you're out rule, and it's like, can we look at that? Can we be a bit more flexible around how we can do that? We've also put people on the mental health exemption, so how we can look at no pay and waiving the co-payment. So for you guys, Friday, 5 o'clock, 10 past 5. Let's think about this. What can you try? Target your clients that are ready to change. Look at, we've changed this now, our drop-in clinics run at the same time as our pharmacotherapy sessions with the doctors. We know that those clients have identified how they want to change their drug use. That's a potential opportunity. Work with the pharmacotherapy prescribers and look at a service model that's accessible, flexible and understanding. Your front of house staff are integral to make that happen. Being friendly, eye-to-eye contact, listening, reflective listening, looking at ways saying, yeah, I'm hearing, yep, you've had a bad time, that's not good for you. Let's look at what we can do. I'm here to help you. Look at your drop-in clinics. When are they run? Are they on simultaneous times? Follow up with staff members with text and reminders, giveaways for incentives. So we've thought about staging our incentives. So rather than, like I said, cash incentive at the start, looking at toothbrushes and those type of things to entice people to come back, and allowing more time for treatment. And I know that's difficult in the model that we've got now, but that's something that we might need to think about if we want to look at maintaining and getting people engaged look after their oral health. So what we'd like to do more of is doing more screening. And in our NSP, we're looking at doing not just oral health, but looking at improving our bloodborne virus screening, looking at an integrated service model with a range of services we've got listed there, and of course our quality improvement process. So we work with the people, our client group, and we call them peers, and they'll often give us feedback and how we can improve on what we're doing. So that's it. Thank you.